Hold on.
Okay, so we are online and recording with Panopto. Okay, so we are continuing with the real-life patient problems presented at the AAD annual meeting last year. So this is from Kathy Schwarzenberger. 65-year-old, 3 to 4 month widespread itchy blisters, and all the tests support pemphigoid, right? So that's your person. So treated with topical corticosteroids. I don't think anyone could say the doses were inadequate here. Mycophenolate, and he says he's just getting worse and he's considering suicide. Which you'll see that with dermatomyositis as well. Patients can tolerate considerable pain. Itch drives them to despair. Okay, so what are you going to do? And it looks like there's a major hint here. She got one of these.
He looks good to me.
You know, hopefully the answer would not be A, right? Clobetasol under occlusion has actually very good efficacy in pemphigoid, much better than pemphigus. And can be equivalent to oral corticosteroids in many cases, but this patient has failed and was, as far as we know, compliant. Tetracycline niacinamide absolutely has efficacy in goid. So in goid versus Gus, which of the two, when we say Gus, we're saying Gus, right? So goid versus Gus, which one is antibody alone all you need to blister? That's Gus.
Got it, yeah.
Right?
Gus.
So any effective therapy for Gus is basically going to target antibody production. Whereas in goid, in order to blister, you must have antibody, inflammatory cells, and complement. All three are required for blistering in goid. Antibody alone is all you need in Gus. So in goid, you have all kinds of things you can target. Tetracycline niacinamide, we're targeting neutrophils, basically, right? You have all sorts of different things that you can target in goid, whereas Gus, antibody alone, will blister you, right? So your treatments in Gus really have to be directed to antibody. When do we pull out things like rituximab for goid when all of the other targeted therapies have failed, which is where you are with this person. And then there's no question that it works. It's just a matter of getting it approved through insurance, because most insurance right now covers Gus, covers lymphoma, covers pemphigus, but they often don't have pemphigoid on their list. So that was skin at time of it.
Like the first year's Retux targets B cells.
Oh, okay. So rituximab is anti-CD20, right? So it's used. We use it for lymphoma, and when the lymphoma recurs, it often recurs because it's CD20 negative now, right? When you are treating immunobullous disease, and thank you, Blake, for pointing out that we should hit the basics. When you're treating for immunobullous disease, and you're treating with rituximab, after your infusions, your CD20 peripheral count should be 0. I mean, you should have wiped out your CD20 cells. as a measure of success of the therapy. And then, of course, there's a lag time in the blistering because antibody, once produced, stays in your system for 6 months. So that's him 2 weeks later. So refractory pemphigoid, even not mild disease, widespread disease can, if you do soak and smear with potent corticosteroids, you are getting significant systemic absorption, but it still may be better tolerated and more efficacious than oral corticosteroids. Oral corticosteroids, there are a number of studies that suggest doses in excess of 1 milligram per kilogram probably are not increasing efficacy for most patients, but certainly increase side effect profile. And then steroid-sparing agents were usually azathioprine and mycophenolate. Methotrexate also plays a role. So, David, how would you dose mycophenolate starting out in an average adult?
I'd start out at, depending how bad they are, maybe start at 500 BID, but if they're pretty symptomatic, you can go ahead and maybe start at 1 gram BID.
Yeah, so gram BID is, usual starting therapeutic dose, although sometimes we'll start a little lower to gauge what tolerance. Where are people intolerant? What's going to happen? Their eyes fall off, their ears bug out, or
it's like nausea, like GI upset, and then
GI upset, correct. So it's not your ears falling off, it's the GI upset tends to be the rate limiting, the dose limiting side effect with mycophenolate. And then where do you push the dose to if they're not responding?
1500 BID is the
so usually 1.5 grams twice daily. And we've always said that's the max, but nowadays you can get blood levels, and people induce the enzyme. So we have patients we're treating who had initial good response, they're no longer responding, and we do blood levels, and their blood levels are subtherapeutic. Your blood level is a morning trough, so before their AM dose. Because the lab, they may not get to the lab till later, they need to know that they're not taking their morning dose to get their blood level done. So if their trough is subtherapeutic, there are two possibilities. Either they've induced the enzyme, which is about 50% of the patients, whose levels will fall when they have documented that they are taking the medicine, and then there's non-compliance. So you sort of have to sort out which one it is and have a frank conversation.
It's one of the acids as well.
I'm sorry?
Antacids, they take it with.
Antacid is brilliant. You're doing really well today in terms of pointing out the key teaching points. Well done. The antacid is the major thing that you would do that would prevent absorption. So, we talk about antacids and calcium and dairy with tetracyclines with patients, but antacids are every bit as important with mycophenolate. And if the patient is GI upset and they're taking antacids periodically, they can have very erratic dosing if they're taking antacids. And then, so Shane, for azathioprine, how are you going to dose that one?
Well, you check a level first.
So check a level of what?
TMP.
Yeah, so thiopurine methyltransferase, which is the enzyme which metabolizes. And so is most of the population normal with that enzyme?
No.
Most of the population is deficient in that enzyme?
Yes.
Just the opposite. Most of the population has too much of the enzyme. So most of the population is homozygous high, which means that for most of the last 70 years we have underdosed Imuran, which is why you read in textbooks, Imuran takes a year to work because we're underdosing people for a year. Right? Imuran doesn't take a year to work. It works on antibody production. It may take up to 6 months, like any drug that's targeting antibody production, because the antibody is still around circulating, right? but if it's taken a year, it's just underdosed. So most of the population is above 20 with the enzyme level. So you don't want the gene assay, you want the quantitative assay. And most of the population is above 20. There's a very small segment of the population, like 0.5% or less of the population that's homozygous low. But the majority of people, 80+%, are homozygous high, not normal range, high range for the enzyme. So if they're homozygous low, you either use microdoses or you just don't use the drug, right? Because it's potentially dangerous. If they are homozygous high, which is most of the population, your risk is underdosing with standard regimens. So you're probably starting at 1.5 milligram per kilo lean body mass, and you know we often have to push it to 2.5. And then methotrexate. So Robbie, you got a patient who pays out of pocket, has a health insurance but no prescription plan, and all of the assistance programs say, sorry, patient doesn't qualify because they have health insurance. They just opted out of the prescription plan, right? So they're paying out of pocket, and it's a choice between food and medicine.
Right.
So how are you gonna, what is the cheapest thing you have up there to treat them with?
The cheapest of all of those would be methotrexate.
Methotrexate, and how do you make it even cheaper? What form?
Is it the liquid form?
Yeah, the liquid
Yeah.
for injection, which is 1/10 the price of the pills,
Right.
and 1/1000th the price of the new methotrexate pills that are out. So we have had patients where we write for methotrexate, they go to the pharmacist and they get a $2,000 bill after insurance, and that's because the pharmacist is supplying one of the new fancy methotrexates. Methotrexate liquid, standard dosing, you're paying maybe $10 a month tops, and you simply you draw a heavy circle on the syringe to where they have to draw it up. They squirt it in orange juice and they swallow it, and they do that once a week. So what's the biggest way you can screw up and someone can be killed with methotrexate? What's the best way to knock out your marrow with methotrexate? Yeah, so taking a midweek dose, right? And there have been several studies that show, you know, the most common presenting signs are oral ulceration or ulceration of their psoriatic plaques. So if their psoriatic plaques are suddenly breaking down and ulcerating, or they're doing mouth ulcers, you want to ask, you know, did you ever take your dose early? And the patients always say, no, never take it early. Did you ever take it late? Yeah, there was the one time I took it 3 days late. Well, when did you take your next dose? On time. Okay, they just took it early, right? And you can knock out your marrow if you do that. So they're always, you know, whatever day you put them on. If they're Friday people, then they're Friday forever. They mark it on the calendar. They cross it off when they take their dose, because older people sometimes can't remember, did they take it? Did they think about taking it? So they cross it off when they take their dose. And if they miss that dose for any reason, they skip the entire week. So we drum it into them. They're never late. They're never early. They skip the entire week if they miss it, because, you know, documented in the literature, almost every case of methotrexate toxicity is a patient who thought they were just taking it late, but they took their next dose on time, which, you know, means they took a midweek when they were nadered, if there counts.
Do you do a test dose?
I do not. I absolutely do not. So that goes back to Howard Maybach and Henry Rennick back when they were first using it for psoriasis, and they had a few people who seemed to have idiosyncratic reactions to small dose, and you know, there's no real subsequent data on that. So lots of people do it. And in fact, that was exactly what the next 20 minutes of conversation was in this case discussion, was about test dose. And about half the audience does, because it was drilled into them, you always do a test dose and check blood count. And about half the audience says, you know, haven't done that in years and never had a problem. And I don't do test dosing. I start them, you know, usually I'm starting them on 12.5, which is half a cc, really easy for them to measure. And that way they get one bottle, which usually costs $8, even without insurance, is lasts them an even month, right? So it's a bottle a month because it's 4 doses. It's 25 per cc, 2 cc bottle. And it says all over it for injection only and discard after you've drawn anything out of it, and they ignore all of that because they're squirting it in orange juice, right? And they don't have to keep it in the fridge or anything like that. So.
And then folic acid. I think we've talked about this before, but for the first year, you were saying there's no data to support, like not or skipping a day of folic acid, like as long as it's less than 2 milligrams.
That is true. Thank you. You guys are doing really well. Pointing out because these are all really important key teaching points. So folic acid we do mainly to decrease the nausea that they can get. You can go up to, in psoriasis, the data are up to 2 milligrams a day of folic acid does not interfere with efficacy, even if given on day of therapy. So there's no reason for them to experience nausea on their day of therapy. You can go ahead and give the folic acid. You don't have to hold it on the day of therapy. Once you get above 2 per day, there is some compromise in efficacy in some of the studies. And that's in doses up to 4 a day, which is where people usually max out on folic acid. So what I do, if someone has nausea on 2 milligrams, but at 4 milligrams they have no nausea, I have them just take 2 milligrams on their day of treatment, and every other day they take 4 milligrams. And then what if someone really overdoses? What if you have that patient who was suicidal and they decide to do it with the methotrexate? First off, it's very hard for them to kill themselves if you're giving them a bottle at a time and the bottle only has 4 doses, right? Because there's not a lethal dose in there. What if you have someone who is stockpiling their, make up a story, right? So, and they now tell you they think they've taken a lethal dose of methotrexate, right? And what are you going to treat them with?
Leucovorin.
Leucovorin. What's the difference between leucovorin and folic acid? Leucovorin is folinic acid, which is the active. So folic acid has to be converted. Leucovorin is already converted. So that's why folic acid is fine. It's easy to get. You can buy it over the counter, right? You can buy big bottles at Costco. Folic acid is fine for the nausea, but for a potentially lethal overdose, it must be folinic acid, which is leucovorin.
Are there any other medication contraindications for your patients besides like Bactrim and NSAIDs?
So that is other key point that we should talk about. So for methotrexate, Bactrim is also folic acid antagonist, right? Which is why you can have cumulative toxicity. Non-steroidals displace methotrexate from protein binding. So it's a different mechanism. They also can decrease renal clearance. Okay. Other drugs that decrease renal clearance, like procaine, that's why they do procaine penicillin to increase your blood levels by decreasing renal clearance, but it's unlikely your patient would be on any of those other medicines. Probenecid is another one that does that. And then for azathioprine, What's the big no-no drug? What's the drug that interacts and kills people? Allopurinol, right? And we do have older people with gout who are on allopurinol, and you know you can really hurt someone with allopurinol plus azathioprine. And there actually is significant safety built into EPIC because you do get a warning. The problem is you get so many dose warnings in EPIC that you got to be a little careful that you actually do have to read them, because if you're just in the habit of dismissing the warning that pops up, sometimes you'll have a warning that really means something. So you do have to actually look at them and see, is it just a weight dosing, which you seem to get on every drug, or is it something else?
I've had come up with methotrexate and aspirin, you know, kind of an NSAID, and then maybe
And
I've
again,
still done it.
it's
but
decreased renal clearance and
it's still
unbinding of protein,
it's not
so
a
that you get
contraindication.
higher blood level. Well, it's a relative.
Relative.
It's a relative. You're giving them a higher dose than you anticipated,
Okay.
essentially. And then rituximab plus IVIG. IVIG increases clearance of immune complexes and immunoglobulin. So through feedback mechanisms, if you're giving lots of immune globulin, your body revs up clearance of immune globulin, right? So if you want to get rid of that antibody faster than 6 months, immune globulin is a way of doing that. If you do immune globulin alone for immunobullous disease, you simply rev up the plasma cell clone and replace it as fast as you're taking it off. Just as like with plasmapheresis. Plasmapheresis by itself was a massive failure for immunobullous disease because you simply rev up your plasma cell clone, right? But what if you want to rev up your plasma cell clone so you can smack it down with a drug like cyclophosphamide? How do you rev it up to make cyclophosphamide more effective? Plasmapheresis, right? So plasmapheresis by itself, you just get rebound antibody production. But you can harness that to rev up that antibody clone and then time your cyclophosphamide so that you smack it down right when you've revved it up. Okay. So that can be used, but IVIG, the benefit is that it may decrease the risk of infection with rituximab. The downsides of IVIG are the expense and a known risk of thromboembolic events. I have killed one patient in my career with drug therapy. That was a patient that we only kept alive for 5 years with IVIG. She had horrible dermatomyositis. She was on a ventilator and respiratory failure. She had basically given up, and she lived for 5 years and had good quality of life because of IVIG, and she died during an infusion of a pulmonary embolus. So, you know, it's not without risk, but there is evidence that it may decrease infectious risk of the drug. So there's a plus minus there.
Do you anticoagulate these patients at all for that risk?
No, you don't. There aren't data on that right now, and they do slow infusion. It's a transient hyperviscosity syndrome. So, but it's not standard of care to anticoagulate. But slow infusion to reduce the risk is standard. And you assess mobility and other things for risk, because there may be someone who ends up in a high risk category where it may be appropriate to anticoagulate, but it's not standard, it's not routine. In terms of dosing, how are you using Ritux? How many of you guys have actually written for it? You know, we always talk about these things, and then there's a difference between seeing someone who's on rituximab and they're doing great versus starting the drug or starting azathioprine. So how many of you have started methotrexate on a patient? and monitored, ordered the labs, etc. How many of you have started azathioprine?
Once.
Mycophenolate. So, you know, you should leave ideally comfortable with all of those things.
For Retox, I think I started in your clinic, but it was, with your assistance, you
Yeah.
gave me the article.
Okay. So, but that's okay. I mean, that's what we're supposed to do. You're not supposed to do it on your own with no assistance, but starting it, it is a different skill set. And that's why continuity clinics are important, and that's also why, for those months where we had no residents at East Cooper, no residents at West Ashley, and almost all the immunobolus patients we were seeing who were new were referred in from Columbia to West Ashley or East Cooper. Doing skin checks here isn't helping you when the immunobolus patients are there. Right? So we're trying to get them back into the clinics and the rapid access clinic and things to get you more exposure. Okay, next one from Kanade Shinkai from UCSF. 25-year-old woman from Puerto Rico, and she's got this fever, rash, low platelets, and it all started on the plane ride to the U.S. That's what you see. So in derm we have color, morphology, and distribution, right? That's what we have to base our diagnoses. So based on color, morphology, and distribution, Brian, you want to launch in where you might go?
So the color in this one is almost like a pinkish red. It's a bright red. They seem to be all monomorphic.
So I'm gonna ask you, is that lesion the same as this lesion, the same as that lesion?
No.
So I'm going to challenge monomorphic, and I'm going to say I see lesions in evolution from macule to papule to what looks like maybe vesicular to eschar and crust. And that probably is important diagnostically.
From the other picture, I mean, it's pretty widespread.
So in terms of distribution, it does seem, at least on the trunk, to be widespread. We don't know if it's purely a truncal distribution or not. So thoughts diagnostically?
No, I mean, it's kind of got that viral look, especially if it was a kid.
Yeah, viral, and what virus might you think of?
I mean, you can think varicella.
Yeah, I mean, varicella would be pretty high on my list based on the lesions in various stages of evolution from macule to eschar. And, looking here, I can confabulate that some of these are umbilicated vesicles, which would certainly be good for varicella, dewdrop on a rose petal, in various stages of evolution from macule to eschar and crust. If you had a single eschar on your ankle and a febrile illness that looked kind of like chicken pox, and you're from Brooklyn,
You're talking like deep fungal?
or rickettsial pox. So rickettsial pox is rare in most of the world, is huge in Moscow and New York City. New York City outer boroughs and Moscow. So, when you talk to most residents, it's something you've read about in textbook. When you talk to the New York residents, the downstate residents, we see it in clinic all the time. Because, it's an endemic disease in New York and Moscow, and I don't know what the connection is there. But, like a lot of rickettsial diseases, they have hotspots, endemic hotspots. Okay, so what would you think of here? So we talked about VZV. What do you think? Let's go up the list. What do you think about TEM?
No.
Probably not. Not with those different stages of evolution and papullovesicular lesions. Mycoplasma-induced rash and mucositis.
I don't think so. It's usually mucous membrane dominant, less cutaneous.
Yeah, it's usually mucous membrane and often has a lot of Steven Johnson type of symptoms. Zika, chikungunya, dengue, you know, they're talking about the patient coming from the islands. But those tend to be more morbilliform eruption, typically. You know, you got to keep an open mind. And the answer was that it was what it appeared to be. So, fever rash, you know, first thing is, you know, you do look, CDC has a great website, you know, this patient just flew in from Mauritania, and the CDC website will tell you what's epidemic in Mauritania right now, right? So you can look at that. And then the other thing was the morphology, which for this lesion was varicella. Pneumonia in adults is 20% or higher, and you know, adults tend to get much sicker than kids. Okay, next one from Yadira Hurley at St. Louis University. 25-year-old African American, hyperpigmented plaques and peripheral livedo, and then she has lymphadenopathy. Right, so we see, you know, from the picture it's hard to tell if they're palpable, but we're being told that they're plaques, which suggests that there's induration to the lesions. A lot of hyperpigmentation. Okay, so what are you going to think of here?
I think I saw this patient in one of my grand rounds.
You think you saw
I
the patient
did,
in grand
yeah.
rounds? Okay, so you were disqualified. And, you know, quite honestly, I think I would probably get a biopsy. You know, it looks more superficial than you'd normally get in eosinophilic fasciitis. Morphia is possible, but, you know, a lot of it could just be PIPA. And it would be an outlier for sarcoid, but like syphilis, sarcoid has a tremendous spectrum of morphology and distribution. Right? So, discussion of silica granuloma. So first off, silica granuloma happens where you have dirt ground in to your skin, and if you develop a silica granuloma, you have sarcoidosis. So it's, you know, no one in this room did not skin their knee as a kid, and yet only some people develop silica granulomas, and those are people with an innate diathesis to perform granulomas. They have sarcoidosis, right? Basically latent sarcoidosis that's brought out by the silica, because it gives them a nidus around which they can form their granulomas. Silicone is injection, soft tissue augmentation. And silicone granuloma is not related to sarcoidosis. So silica is not the same as silicone. Right? Silicone is a fairly inert substance, but it tends to migrate in tissue. So when people are getting larger amounts for augmentation, sclerosing agents are added to keep it from migrating, and most of the complications come from those sclerosing agents that were added to try to scar down the tissue and keep it from migrating. So in New York at St. Luke's, we saw patients who had, quote, had their calves done, you know, their calves augmented, and they had this horrible ulcerative, indurated ulcerative plaques with draining sinus tracts. So, you know, you see that sort of thing, and then you see the same thing with breast and penile augmentation attempts with silicone. And then histologically, it looks like Swiss cheese with big ones and little ones. And if you do frozen section, you can see that there's material in those. And you have some things that look almost like mucophages, where they're picking up vacuolated cells that have picked up the silicone. and you know, a lot of the reaction is probably the sclerosing agents, not the silicone itself. So you have the impurities and adulterants are a big thing, but there's also microbial. You know, some of these patients have had mycobacterial contamination. You know, a lot of these are back alley type of augmentations, and it may shock you, but they're not entirely sterile.
Do you also see the reaction at the site of augmentation?
You do. You see it at the site of augmentation and the areas
And where
to
it's
which it
done.
migrates.
So she had silicone in her buttock.
She probably had buttock augmentation done.
I think she had it, and I think it was local, but she couldn't remember who it was, so they were trying to find like the doctor that did it. She had no idea.
We see silicone usage in the U.S. has gone down, but you see a lot of it. The reason they can't remember the doctor is it wasn't a doctor.
Yeah,
who did it.
exactly.
And there are lots of people who go overseas to cosmetic clinics that are less expensive, and there's some very high-end cosmetic clinics that are using it overseas. So, you know, all of the various, you can read the list of everything that's there. Okay, so how are you going to treat? And these are not easy. You know, there's probably a role for everything in that list in some patients. And so that's some of the references that she gave. Okay, from Alex Miller. So this patient, who you know obviously has paralysis of the one side, and you want to know where are they in relation to their procedure and injection. Did you just inject xylocaine? You know, what exactly happened here? And the answer was it's paralysis of the central facial nerve, and you can get Bell's palsy, but you can induce the same thing with injection. So, you know, when you've just done surgery on a patient and you have a lid lag and asymmetry of the eyebrows, you don't immediately panic and send them to plastics. You wait a couple of hours because the function's almost certainly going to come back. It's just you've numbed the nerve. Okay, so superficial temporal, you know, you have to know danger sites in derm. So what's the one with the posterior triangle? Where's that? And what's going to happen?
Herb's point?
Yeah, so posterior triangle is where?
It's like sternocleidomastoid, like
Exactly. So
anterior.
what you do is you want to,
Find the
the
mass.
nerve comes out at what level? It's below what muscle? Comes out under your trapezius, right? So it's what innervates your trapezius. So what you're going to get is a shoulder drop, right? And it goes in the underside of the trapezius. So where there is no trapezius, so what you do is you push your chin against your hands. So you're tensing up your trapezius, right? And you feel where your trapezius ends. That's where it's going to come out, but it's not on the superficial fat. It's lying at the level of the underside of the trapezius, right? So it's exposed and there's only fat above it, but it's at the very bottom of that fat, right? Because it comes out at the level of the underside of the trapezius. So you can do surgery in that area, you just don't go to the base of the fat because that's where the nerve is, right? Where does it go more superficial than that? So two big nerves that we have to worry about, plus the supratrochlear, right? So supratrochlear is somewhat of an issue, but your big one is superficial temporal, right, which is right in there, you know, and it's about a 2 centimeter zone in your temple where it can run either side there. and that goes, fairly superficial, and that one is motor or sensory? That one's motor. And then how about the one that comes out of your mental foramen? That one's sensory, correct. And that goes through your lip, and where your danger zone is not so much where it's exiting the foramen, but it travels right in through your minor salivary glands. So if you take your tongue, put it in the middle of your lower lip, you don't feel much, right? Now put it right there, and it feels like tapioca pudding with all sorts of little bumps in there. Those are your minor salivary glands. When you're going in to do a minor salivary gland biopsy, or more commonly repair a mucocele, where do you get mucoceles? Right there, right where that nerve traverses. So mucocele repair, you've got to be really, really careful. And minor salivary gland biopsy, you do not snip for either of those. Because if you cut the nerve, you know what it feels like when you've been to the dentist and you're numb on that half of the lower lip? Your patient will be like that for life. And they will hunt you down and kill you. Right? So you don't snip in those areas, because that's really danger zone for a sensory nerve.
What's the proper way to do it? Like to just get my
Okay, so if you're doing minor salivary gland biopsy, it's super easy. You anesthetize on the mucosal side, right over where, you know from your own lip where those are, right? And I usually have the patient go with their tongue, so they're feeling, I talk to them about the nerve going through there. Anesthetize on the mucosal side. Usually go see another patient to let the edema resolve and then come back, right? And then at that point, you do simply an incision slit to get onto the mucosal side. You go in with gradles or iris scissors, some sort of small scissor, and you spread, never snip, spread, never snip. What do you never do? Snip, thank you. And then you squeeze, and these things that look like little round pearls of fat pop out, and you pop those in a bottle. And those are your minor salivary glands. High yield for Sjogren's, equivalent or higher yield compared to abdominal fat pad for amyloid, right? And they're complementary. So they're cases that you miss with either one but pick it up for the other. So if they're really thinking amyloid and they're asking abdominal fat pad, we'll often do both to give a higher yield, right? And then for abdominal fat pad, I basically make an incision, take out a hunk of fat, and then do a vertical mattress closure to close that dead space. And the reason I'm doing a vertical mattress closure is if they have amyloidosis, all those vessels are going to bleed like stink, right? Because they're rigid. And sometimes, if they're really bleeding, you throw some gel foam in there, and then you just close over the gel foam with a vertical mattress. So it gives you expansile hemostasis in there, and then just slowly goes away over time. And I don't do an ellipse because in the lab they're going to be so focused on treating it like an excision that they tend to ignore the fat, right? And what you're really interested in is the fat. So that's about it. And mucocele, again, initially score it to define it and take it out, but you can usually dissect out a mucocele with blunt dissection, and you want to avoid snipping whenever you can.
What about marginal mandibular? Do you worry about that as it crosses the?
Yeah, that is, it is another of the danger points. But if you look at data on actual lawsuits in dermatology, at UT Houston, they've only been sued like 3 times, and 2 of those suits were for sensory neuropathy after salivary gland.
Oh.
So,
For the technical branch, like Dr. Beach talks about, dissecting carefully, but is there any, besides just being careful and staying superficial as possible, is there any
yeah, stay as superficial, and it really becomes an issue in Mohs, where often you have to isolate the nerve, identify the nerve, mark the nerve. You're trying to go around the nerve, but if the tumor is perineural in that nerve, then you have a frank conversation with the patient because your choices are irradiation, Vismo, or sacrificing the nerve at that point. How we doing time-wise? So these we do for the new first years. We do 2 different types of image sessions. We still call them Kodachromes because we're old guys, right? But we do these that are kind of practical, tough problems that move kind of slowly, but there's a lot of meat in them, the teaching points. And then we do rapid fire, what's the diagnosis, what's the color morphology distribution that gives you the diagnosis, with maybe just a little bit on treatment. And we tend to alternate them. So we do one of the rapid fire, cover a lot of ground sessions, and then one of these. And I think each one has its use and role. So that's the distribution where the nerve can run. And then there's your marginal mandibular, and there's your mental midline, and those are all potential danger zones. So this is one where you're on top of marginal mandibular, and all you need to know all of your danger sites, but you get a sense of exactly how deep this one is, right? I think the reason that this gets hit so much more often is it's so superficial. I mean, it's running right at the level where your mucocele is. It's running right through the middle of that. So it's not a matter of avoid it by not going deep. It's a matter of don't snip, do everything by blunt dissection. Okay, so severe abdominal pain, exquisitely tender plaque, 6 months, and then she had a big GI workup, and it was unremarkable. And you see some sort of lesion there as well as the surrounding erythema. And this is, let's see if we can get rid of that and see who is. So this is Elaine Siegfried, also from St. Louis, right? Peds-Derm. So, what are you gonna do in this case?
B.
At least A, right? At least A is a starting point. So in this case, it's factitial staining was the answer. So someone with, factitial disorder and secondary gain and, creating lesions. So these are, on the left looks more like terra firmiform dermatosis, which the patients can't wash it off, but you can remove it with alcohol. And that's in fact how you do it therapeutically, is you remove it with alcohol. And that's essentially a retention hyperkeratosis. So, in this case, her point was none of these terra firmiform dermatosis is not acanthosis nigricans. You see it very commonly in atopics, and it's retention hyperkeratosis, but it has nothing to do with acanthosis nigricans. You can get rid of, you can remove this with ethanol. Acanthosis nigricans does not alter with ethanol. Okay, here's another skin staining that's pretty dramatic. In that case, that was selenium sulfide. And these are all skin staining. There are, you see it with millipedes and things too, where kids will have these arcuate lesions, and the parents often get turned in for child abuse because it looks like you whipped them with a belt or something, but it's millipedes got in the clothesline, and the millipede, when you're scrunching it, moving around, its self-defense is it oozes this stuff that gives you a burn, essentially, that hyperpigments in a very arcuate recognizable manner. In this case, it was walnuts. And that one's silver nitrate. And so acne topicals, sulfacetamide, and all the various medicaments that can give you skin staining. Right. Okay, next one from Tony Fernandez at Cleveland Clinic. Remember, Tony is the one who had the guy who looked like a plaque of psoriasis on his arm, solitary plaque that was teeming with spirochetes on stain. Also, interesting follow-up. So remember the kid we told you about? The question was neonatal lupus. Mom, aunts have one history of lupus. It was mucin in the dermis, superficial and deep infiltrate. On biopsy, turned out dad was positive for syphilis, as was mom, as was baby. And the skin lesion with spirochete stain once dad was diagnosed. There was in the last journal of cutaneous pathology, they had report of syphilis presenting with only dermal mucin. That's the only finding. So it looked like a dermal mucinous nevus. And so in this kid, the dermal mucin with the question of lupus really put us down the wrong path. But, sarcoid and syphilis, great imitators. Okay, so this is 70-year-old man, this duration, or this eruption, 2 months duration. So, David, what kind of things are you going to think?
He's got bad mucositis. It's too kind of chronic to be like TEN or SJS.
Yeah, so it's a
What do you think
little
about that?
chronic to be TEN or SJS, but it has that kind of look. So then what are you thinking?
Paraneoplastic Pemphigus.
Yeah, you're probably thinking PNP, 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 or PNP first, right? And then it could be other things, but an old guy with something that's smoldering and looks like Stevens-Johnson, you're probably thinking paraneoplastic pemphigus as the top of the list, right? Looking at his arms, so is that a bright red or is that more like a pink to slightly violaceous?
Yeah, it's pink to violaceous.
And that might even, with a distribution on the upper back and a pink to violaceous extensors, what might you think of there?
It's more like a TBH.
Or I'm thinking dermatomyositis, with a shawl sign and extensors and kind of more pink than red. And if he's paraneoplastic, I mean, he could have PNP and paraneoplastic dermatomyositis potentially. Okay, so what's the most likely cause? Sure, it could be medication, but non-Hodgkin's lymphoma if it's PNP, right? And then that's kind of sneaky because you get a number of antibodies in PNP, right? But in this case, in non-Hodgkin's, it was paraneoplastic pemphigus. So ordinary pemphigus starts where? Where do patients present first?
Oral mucosa.
Oral mucosa. What part of the oral mucosa?
Gingiva. Roof of the mouth.
Usually non-attached mucosa. Usually non-attached mucosa. And the patients often start, you can see it with gingiva as well, but it's often non-attached mucosa. And the patient says, can't drink orange juice anymore. It just rips my mouth apart. That's often an old Jewish guy who can no longer drink orange juice is pemphigus till proven otherwise, right? Just in terms of age demographic and symptomatology. Whereas PNP, you get a lot more lips than you get in ordinary pemphigus. So PNP likes the lips, so you're thinking that more. So why does pemphigus present in the oral mucosa? Why does it do that before skin?
Because there's only doesn't weigh 3 in oral mucosa.
Exactly. You got 2 glues in your skin, you only got 1 in your mouth, and it's the one that's targeted by the disease. Right? So ordinary pemphigus targets desmoglein 3, one of the two glues in the skin. Skin has both desmoglein 1 and desmoglein 3. Mucosa only has desmoglein 3. There's nothing else to hold your skin, your mucosa together. So, you know, you got Castleman's, usually hematopoietic. And then, you know, these are all of the various antigens that are targeted, which include BP1, which is not the pathogenic BP antigen. That's BP2, the 180. And the desmoplakins more than desmogleins. So the glue attaches to a plaque in the desmosome, right? It's the plaque portion that's targeted in PNP, not the glue portion. So it tends to be plakins that are, you know, you look at the list, almost everything's a plakin, right? So it's the plaque of the desmosome, not the glue of the desmosome. But you have crossover. And in fact, I think several of you have seen the patient that we had at East Cooper, really nice Italian woman who presented with gray lips, and that was her presentation of her gut cancer. So she had not classic PNP, she had pemphigus that is paraneoplastic. So there's PNP, which is a disease, but any pemphigus can be paraneoplastic. So she had more like a pemphigus vulgaris that was paraneoplastic, and she may kind of fall into this category where, you know, maybe she has some plakins and things too, but, you know, mostly what she had was desmoglein 3.
Is there certain cancers that are more likely with the pemphigus that's paraneoplastic?
So PNP tends to be hematopoietic and Castleman's, whereas pemphigus that's paraneoplastic is age-associated tumors. So, you know, lung, breast, GI, the things people get at that age. So in her case, she was overdue for a colonoscopy, and on colonoscopy they found her gut cancer, and you know, she's a trooper. She's been through her chemo, she's on her second round of Ritux therapy, and she's doing well. Okay, so remember on biopsy, it can get read as EM, and sometimes you're thinking EM looking at the lips, right? The biopsy, if you say rule out EM, and the pathologist isn't thinking PNP, it looks a lot like EM, right, with lots of dead reds. And it can be called lichen planus, too. Again, because of the necrotic apoptotic keratinocytes. And then, you know, mouth first, and vermilion is typical and similar to SJS, whereas regular pemphigus does not tend to be on the vermilion. Right? When you see vermilion, you think cancer. Okay, so this is a typical biopsy, and you know, you can have lichenoid or vacuolar interface, lots of dead reds, so it can look either like LP or EM. You know, acute stratum corneum, individual necrosis of keratinocytes and lymphs. And you tend to get both a chicken wire pattern as well as a basement membrane zone. So the basement membrane zone is the BP antigen, which is commonly there, you know, the non-pathogenic BP1 antigen. And then the chicken wire, see how the chicken wire is a little bit dot pattern? Not what you get with ordinary pemphigus. Ordinary pemphigus, it's the glue that's being stained, and it tends to be more uniform chicken wire, whereas here it's the plaque of the desmosomes, so you're really seeing individual desmosomal staining. Now desmoglein is associated with the desmosome too, but when you look at it, this does tend to be more dot-like. So it looks like, you know, if you were to see a prickle cell layer, like think of spongiatic dermatitis, where you have all of those little prickles holding on, those little spines of the spinous layer. They're holding on to the desmosomes, right? Those are little desmosomal attachments. So it's kind of the distribution, like you'd see those little spines in a spongiatic dermatitis, is what you see with PNP. And then treatment is tough. So a lot of these people, what's the if you're going to die of PNP, what organ is going to crump? Lung. So you get bronchiolitis obliterans. So BOOP. You know, BOOP sounds like your pal's nickname, but it's not a nice thing. You know, BOOP is really, really bad. And you may need total, if they don't respond to rituximab, they may need total immunoablative therapy, where, you know, the computer is so bad that the only thing they can do is wipe the disk. You know, just wipe out the immune system and totally repopulate a new immune system. Okay. And we're out of time. So let's see where we... So that one we were on 285. Okay, so then we pick up again on this one. So the next one will be a high, rapid fire, high yield image thing. And then back to one of these. It'll be 285. Several of you put it in your cell phones. Okay. Because otherwise, you know, you count it on someone who's on vacation.
Thank you.